The first live.
Like the panelists to be there, or they can sit?
No. I'll just call him. I think we are ready before we go to the cath lab. Can I request the expert panels to be on the table? Can I request Major General Tahir Iqbal, Professor Azim Azhar Mahmood Kiani, General Azhar Mahmood Kiani, and Professor Sajid Dhakum, Dr. Ahmed Adris, Dr. Javed Iqbal, Dr. Muhammad Raza, and Dr. Asad Pathan, and Dr. Nasir Ahmed Samoor. Please come over here on the panel, and we then start. AFIC Cath Lab, hello. Hello, Sohail, can you hear me?
Fab. Hi, yes, I can hear you loud and clear.
Oh, hi. How are you, Sohail? Are you all right?
I'm very well, thank you. So
good to see you.
We've been up early today, and we've been working away here. So we've got a great case for you. I'm working here with my colleagues. I've been invited here to the Armed Forces Institute of Cardiology. It's always fantastic to come back to Rawalpindi to work with old colleagues who were previously my fellows, and it's good to see that they're consultants now in this country. Good. So I'm going to hand you over to General Tayyab, and he's going to hopefully describe the case that we've got today, and then we'll be interested to see and hear what the panel have to think before we tell you what our strategy is going to be in terms of how we go ahead and treat this gentleman. So it's a coronary case. So I'm going to hand over now to General Tayyab now. So, sorry, General Farhan. Sorry.
It's okay.
Yes, General Farhan Tayyab, how are you?
And welcome to the Cath Lab FIC. This is Cath Lab A, and we have lined up a case.
Can you increase the volume, General Farhan? We can't hear properly. Can you increase the volume, please?
He has a very diffuse disease, and
एक second. You have to speak into my mic. Sorry, we've only got one mic here, so.
Okay, so we have a patient who is 65 years of age. He's a male, and he has had angioplasty to LED into 2016, and he had very diffuse disease, and he had 2 stents from proximal to distal course, and now he is presented with effort angina, and a re-angiogram showed that he had diffuse disease at ISR, and we are going to plan how to treat it today. His EF is normal and his labs are normal, so no worries about that. So this case lined up. We'll show you the angiogram now.
Yes, please.
Can you show him the angiogram?
Can we see the angio pictures?
Back, please.
In the meantime, while we were waiting, we got access from the femoral, and then we have placed a San French guide, and then we wired him with a workhorse wire, and we've already done some ballooning, and now we will plan further. I'll just show you the angiogram now.
And how many stents were put in? How many stents?
So there were 2 stents that were put in originally. I think they were done in 2016. Right. They were both drug-eluting stents. The distal one was a 2.5 by 40 millimeters, and the more proximal stent was a 2.75 by 40 millimeter stent.
Right.
Can you just let that angiogram run, please? Does next picture? Yeah. So we've got a 7 French guide in place. It's slightly short, as you can see. This is a 3.0 guide, but we've been able to wire the LED. This is a run-through wire that we've put down here, and that's the first angiogram picture. So you can see that there is diffuse in-stent restenosis in these drug-eluting stents. So I'd be interested to hear what you think and what the panel thinks in terms of how they should go about treating this.
Right.
So I'm going to hand back to you, and why don't we sort of poll the panel, if you like, and see what other individuals would do in terms of treating this lesion.
Thank you. So we have Brigadier Nasir Samoor. So Nasir Samoor, this is your patient, and you see 65 years old, previous history of 2 stents, diffuse ISR. What will be your approach in this patient?
I think, sir, I would like to wire the LED and
will pre-dilate the lesion I would first like to know the size of the stents which were previously deployed.
Under the bind, please.
And I'll do pre-dilatation by escalation of balloons, and will one-to-one pre-dilatation. And after optimizing, I would like to, if it is instant restenosis, I would like to dab it. And if there is a marginal instant restenosis, I would like to cover it with the stent.
General Tahir Iqbal, any comments or your approach?
Disease that after these two stents that he had ISR, the history would be important, and the risk factors are certainly important, but as far as the approach for the management is concerned, even with the ISR, I can see a critical disease before the stent. And it looks like that we can encounter a lot of calcium here. So I would be ready to do even rota before the stents. It's so that is something which will be very, very tricky in the presence of these stents. That before those lesions.
Foot switch, please.
Right.
Before those lesions, I can see that critical disease and the calcium there. So I don't know what are the plans of the operators.
Suhail, you see, before we proceed, we know that there are different options to treat ISR, which is one of the challenging situations. Should we assess this, I think, whether it is new atherosclerosis or it is under expansion? So I think I would like to take your views that how would you assess the reason for this ISR? Because in terms of, you see, the stent expansion or new atherosclerosis, so do you have any plan to reassess in terms of imaging or anything else like that?
Yeah, so actually, you know, these are drug-eluting stents, and we know when drug-eluting stents came about, they reduced in-stent restenosis quite significantly. However, they didn't reduce the incidence of in-stent restenosis to 0%. So there are reasons why stents will still run into problems and you will develop in-stent restenosis. The most likely mechanism here, I think, is probably stent under-deployment. This is a 2.75 stent that has been put in the proximal segment of the LAD, and I think that is way too small for this vessel. The other concern, of course, here is the length of stent. So we know that there is a relationship between in-stent restenosis and the length of stent that is put in, regardless of whether that is a bare metal or drug-eluting stent. So I think there are two main reasons why this patient has developed in-stent restenosis, probably the length of stent that has gone in and probably undersized stenting in the proximal segment. Intracoronary imaging is certainly going to be useful here. We discussed whether we should be doing that or not. Actually, we don't have the IVUS available, otherwise we would have put an IVUS catheter down, but I'm pretty sure what the IVUS would have shown is that the stents in that proximal segment are under-deployed and probably malopposed to the vessel wall as well. So what we've done here is actually, if we go to the next picture, please. We've gone ahead and we've just gently ballooned the vessel here, because you can see that the flow down the vessel is a little bit sluggish. It was sort of Timmy 2 flow. He was beginning to get a little bit of chest pain as we had our guide catheter in, and whilst we were waiting for you to come online. So we've gone ahead and we've ballooned this with a 2.5 balloon just past that diagonal branch, and that's improved the flow now. And you can see in this very proximal segment, you can see dog boning of this 2.5 balloon, which suggests that actually there is probably some calcification in that proximal segment, which has probably restricted the expansion of the stent, although the stent is probably small in that proximal segment anyway, the 275. So next picture, please. So this is kind of where we're up to now. So that's what we've done so far.
Right. So what will be your strategy now to see from here onwards?
Well, there are lots of things that you could consider for this patient, including treatment with drug-eluting balloon therapy. You could think about expanding the stents in the proximal LAD segment with non-compliant balloons. But our concern is, because of the restriction in the 2.5 stent, there is probably some calcification in that segment of vessel. So what they've recently acquired here at the Armed Forces Institute of Cardiology is the Spectranetics laser catheter. So we're hoping to show you a live case demonstration. I think it's going to be the first live case demonstration of the use of laser catheter in Pakistan. So maybe we can just swing round to the console here so we can explain some of the setup to you. So if we could just focus in on the panel there. So remember, laser has been around since the 1980s, and it was originally used for peripheral work. And then the coronary indications came a little bit later, sort of late 80s, early 90s. And one of the problems when laser catheter was introduced was that it basically meant that with the old catheters that we were using, there was a risk of perforation and vessel dissection. Now, of course, technology has moved on since that time, which has meant that actually we've now got newer catheters available which have a reduced risk of causing perforation or dissection. So the main indications for using laser atherectomy, which we're going to show you here, is of course in-stent restenosis. So that's a prime example of where you might want to use it. Patients in whom you can get a wire across a lesion, but you cannot get any microballoons down, so a CTO case where a wire is able to cross. And in patients who have vein grafts, and also patients who have extensive thrombus. So we've used it in primary PCI settings as well, where there's extensive thrombus in the vessel. Now, how the laser works is it uses ultraviolet light at 308 nanometers, so it's low bandwidth light, and it basically has a threefold action. So it breaks the carbon-to-carbon bonds within the tissue. It also causes heat to be generated, which causes the water within the cells to expand, so you get cell expansion, and as a result, you also get a small thermo expansion effect at the tip of the catheter as you're advancing the laser up and down the vessel. So the catheter itself, I don't know if you can see this or not. It's basically a 0.9 millimeter catheter. It comes in four sizes. The 0.9 and the 1.4 are 6 French compatible. We have a 7 French here, so it's not going to be an issue passing this catheter into the vessel. And I don't know if you can see my hand. There's a red light at the tip of it, which is basically the eccentric laser electrodes which are placed eccentrically around this catheter tip. So we've already calibrated this device, and we're going to start advancing this up into the patient. Now, you probably noticed that we're all wearing these tinted glasses, and we know that the laser has an effect essentially on the eyes, so we are all having to protect our eyes, including the patient. And we've put a sign up on the front of the door to say that nobody should be walking into the cath lab as we're lasing within the patient.
Sohail, what is the crossing profile of this catheter? You need to have pre-dilatation, good, or
no. So we did pre-dilate here, but we pre-dilated because there was reduced flow in the LED. But it wouldn't have been an issue trying to get this catheter down into the coronary. It has a very good crossing profile. So I'm going to just get you to focus in on the console now. So if you could start advancing the catheter, please, guys. And no. So what you can see there are two important things to note here. On the left, you can see that there is a fluency rate and that is measured in millijoules per millimeter squared. And essentially what that is the amount of energy that we are going to deliver within the coronary artery. The other thing on the right-hand side is the frequency or the rate, so the number of pulses that we will deliver and generate in a second. Now the 0.9 millimeter catheter will allow us to deliver up to 80 millijoules of energy at a rate of 80. So what we're going to do, we're going to go straight up to 80 on the setup here. 80, please. Yeah, and if you could also increase the frequency to 80 as well. So the 0.9 millimeter catheter is probably the most frequently used catheter, and it will deliver the pulses over a 10-second train, and the console will then have to rest for 5 seconds. Now, when we're delivering the energy, we will need to do it carefully because there is a risk of dissection. But in this situation, of course, there's stents within the vessel, so the chance of that is low, and the chance of perforation is low as well. So we're just advancing our catheter. So can we go in on the coronary angiogram? Okay.
So what is the standard pulse?
So similar.
What is the standard pulse rate you set for the most of the cases?
So in most of the cases, particularly in in-stent restenosis, you want to deliver high energy and you want to do it at a high frequency rate. So in those situations, I tend to go straight with 80-80. Where you're trying to dissolve thrombus, then I will go down to a lower fluency rate. And if we're dealing with degenerative vein grafts particularly, then we would deliver it at sort of 45 fluency and a rate of about 60. But you can make those adjustments
please go ahead,
as you go along.
You have about 20 minutes more.
Okay,
Sir,
yeah.
can I ask a question, if you allow me? Sir, can I ask?
I'm going to just show you this setup here as well very quickly. So when we're lasing, we want to lase in saline and not contrast, because what happens is if you lase in contrast, you get microbubble formation, and you can get sort of mini volcanic eruptions, if you like. So we've put a 20 mil saline tube on here. And as Dr. Macon is going to advance the laser catheter and put his foot on the pedal, you should hopefully hear the noise of the laser catheter going. And I'm going to be injecting the saline continuously whilst he's doing that over a 10-second period.
There is one question from the audience before you go.
Yes, I'm Dr. Fawad Farooq from NICVD.
Inject.
Pre-ballooning,
Slowly.
rotablation, and this laser are all modalities of bed preparation. So at what stage you'll advocate use of laser? It is prior to rotablation, prior to aggressive ballooning, or after that? Because you, I think, ballooned in this case, 2.5 balloon you used for pre-dilatation. Can't we go beyond that before for preparation of bed and then advocate using laser in between rota, or just straight away laser for the first go? So that's the question regarding this.
Yes.
I just want to concentrate to show the procedure. We can answer later.
Thank you. Sorry. So I only caught part of that question. My earpiece has fallen out. So
I mean, the question was from Dr. Fawad Farooq that do you need any further prep before you use the laser, like rotablation or something, or you just go ahead and do the laser after pre-dilatation?
So the data on rotablation, we have some prospective data, but we don't have any randomized control data of rotablation in dealing with in-stent restenosis. What we know is that there is a higher risk of causing no reflow with rotablation, probably in the order of about 3 to 4%. And we haven't seen that in patients in whom we've done laser atherectomy for treatment of in-stent restenosis. So remember, what happens is that we get fine particulate matter formed, probably less than 10 microns in diameter, and that's taken up by the reticuloendothelial system. So no reflow is certainly lower with laser atherectomy.
So can you demonstrate
the other point that's important.
Sorry, can you demonstrate the technique, how we move, like you see, how we use...
So I don't know if you can see the angiogram at the moment. What we're doing is we're advancing the laser catheter at 0.5 to 1 millimeter per second up and down this LAD. And the nice thing about laser atherectomy is that you can perform laser atherectomy as you're going down the vessel, but also as you're coming back up the vessel as well. So Dr. Macon is just advanced into the mid-LAD now, and he's going to be bringing the catheter back up into the proximal LAD. Now, laser atherectomy is also useful for moderate calcification, so there is an indication to use it in moderately calcified vessels. Obviously, severe concentric calcification will need to be dealt with rotablation. The other thing is that, of course, we have very little data on rotablating within stents. I don't know if anybody has tried that on the panel, but I haven't had very good experiences of rotablating stents. You usually get a horrible noise as you're rotablating a stent, and you get you're at a higher risk of causing deceleration of the burr and getting your burr stuck as well. So we're just working on this lesion at the moment, and if we swing back round to the console here, can you just go to pulses delivered? Can somebody just press pulses delivered on that? Can you go round and press the pulses? Yeah. Okay. Yes. Pulses delivered. Press करें please. Press करें. Pulses delivered. Okay. Yeah. Up press करें please. Okay. So now what you can see is that we've pressed the pulses delivered button here, and you can see what we're aiming to do is probably to deliver about 10 to 12,000 of pulses within the vessel here itself. Now, the pulses delivered obviously depend on your frequency rate, and if you reduce your frequency rate, then your pulses will go down as well. So these pulses are racking up quite quickly because we're at a high frequency, a high fluency rate as well. Okay.
Any questions or comments from the
panel?
panel?
3020 NC. 3020 NC.
Any questions or comments?
Can I ask a question?
Yes.
We want to deliver 10,000.
Which is centered and with such a diffuse disease.
Yes, please.
I would first.
So I don't know if there are any
how big
questions
was the
from the
artery
audience.
and how much under-deployed this stent is before embarking on to any revascularization procedure. Otherwise, the restenosis is going to be terrible one more time.
Yes.
And I have a feeling that you have to achieve a very good head space. I mean, the optimal diameter could be much more than what we see. And after that, you can do dab or laser or whatever, but you have to achieve good diameter, and that can only be possible with an imaging.
Yes, I think we have already discussed the imaging that ideally it should be done, and we see the diameter and the under expansion or over expansion of the stent, and to find whether it is new atherosclerosis or something.
Sir, another thing with imaging, we can also find out the exact mechanism of the in-stent restenosis. Whether it is a stent under expansion, whether it is a malapose stent, or whether it's new atherosclerosis. Because this will also change the modality of our treatment for that ISR.
This is all, we have already discussed this in the beginning, so we just missed that. Right, so so where we are now?
I mean, unfortunately, we had a problem with the IVUS this morning because we were planning to use IVUS up front. As you know, I'm a big user of intravascular coronary imaging, but we haven't been able to do that. No, what we've done now is, so we've just switched our syringe round to contrast. So because we've got a stent in here, I wouldn't advise this if you're starting up doing a laser atherectomy, but I'm an experienced operator, and we're going to lase within the contrast, and this is going to cause some microbubbles, and we're hoping that will cause some disruption in that proximal LED stent. So we're going to just lase the proximal segment only now. So,
Ask a question. Sohail Khan, this is Amber Malik here.
can we just do the proximal LED only
Can't
now?
hear me?
Yeah. So bring it back.
There is a question from the
So bring
audience.
it back to the proximal. Proximal LED.
He can't hear us.
हाँ यहाँ पे
They are probably concentrating.
यहाँ से शुरू करें. Yes. Let's come on now. Come on. Let's go. Okay, so what we're doing is we're just lasing within the proximal LED, and we're delivering contrast at the same time. And what this will do is it will cause microbubble formation within the proximal LED, which we're hoping will cause some disruption in the calcification. We've delivered 10,000 pulses now, so we're going to come out with our catheter now. So this is our final run now. Why don't we come out with a catheter? And let's take a 3020 NC balloon or 15 NC balloon now. 3015 or 20 NC. Yes, can we have it, please? Yeah.
There is one question from the audience.
Yeah, so let's
Amber,
get the
repeat?
guide in, and let's take a picture now.
We have one question from the audience, Amber.
Yeah.
Can you hear me, Sohail Khan? It's Amber Malik
Yes,
here.
yes, Amber.
Yes,
I
hi.
can hear you.
Just
Hi.
a question. We are beginning to use rotablator more frequently in our labs all over the country, and there's always been a rotablator fear, and getting a stuck rota or something, and you have to be very careful with you go in and out and come back and land in a normal segment. But with the laser, it seems that that is not a problem, and you can park your catheter anywhere. Is that right? And
Yeah, so-
I mean, it
so
has
the
different
nice thing about
technique to
the-
it.
Yeah, so the nice thing about laser is that you can do it on your regular workhorse wire. So
Good, yeah.
any 0.014 wire. It doesn't have to be an 0.009 wire or 10 wire that you use for rotablation. And if you can get your wire across in the CTO,
Yeah.
we've all been in difficult situations
Yes.
where we cannot get the smallest micro balloon across
Absolutely.
that we have on our shelves, and we have to abandon the case.
Yes.
So in those situations, in those circumstances, in our cath lab, we would then automatically just reach for the laser atherectomy catheter.
Yeah.
And we've had 100% success with it, where we've basically managed to cross with the laser atherectomy catheter, and then that will then facilitate a micro balloon to go down, and you can prepare the lesion and the vessel and deploy your stents.
Right. I think just a couple of weeks ago, I think we had a similar scenario, and that's what we were missing in our cath lab, that we can't get anything across, a wire across the CTO, but no balloon, essentially. So that's a good place. And a stent, under-expanded stent with ISR is another good indication for that.
Yeah,
Yeah.
absolutely.
Okay, great. Thank
so
you.
These are sort of the 4 or 5 main indications for it. So under-expanded stent, in-stent restenosis, extensive thrombus, and a CTO case where you can get your wire across, but no other device will go down. And also it works in mild to moderate calcification as well. So
Can it be done
did
with
that
6
balloon come
French
up with that
guider?
proximal LED?
Just a question, can it be done with 6 French guider because you're using 7 French here?
Yeah, we've gone with 7 French here just to give us a little bit more wiggle room. So the 0.9 millimeter and also the 1.4 will both go up a 6 French guide catheter.
Right, Sohail, now we have 8 minutes more to go. So what will be your further steps? Further steps from now.
So I don't know, can you see the angiogram screen now? You should be able to see where previously we weren't able to get the balloon up in the proximal LED segment. We've now been able to do that quite successfully. Right. So can we just come AP caudal, please? Yeah, and then we'll just dilate the proximal LED here. So.
I mean, despite the laser, we still have
So,
some
so our
stenosis.
strategy,
We still have quite significant
so
stenosis
our
proximally.
strategy, yeah. So can you see, there's also, I think the other issue here is that the stent that was put was landed into a diseased artery. So the very proximal segment of the LED is diseased, but it wasn't stented the first time round. And we know that there is a higher risk of edge restenosis, particularly if you stent into a segment of vessel which has more than 50% plaque burden. And we know that there's been some recent data from the Chinese group, from the Ultimate study, which showed that actually if you try and optimize your stent, achieving areas with intravascular ultrasound above 5.5 millimeters squared, then you will get a very good result. But you also need to avoid stenting into proximal and distal diseased segments of vessels. So if you've got a 50% plaque burden, you should probably treat that rather than leave it untreated. So the angiogram now is, in fact, can we go back 2 pictures? I just want to show the balloon inflation in the proximal segment. Yeah, this. So let's just show this picture. So you can see that this is a 3.0, I think 15 or 20 NC balloon, and it's come up very nicely in that segment of LED. If we go forward now.
Just a question, why haven't you upgraded this balloon prior to laser? You just stopped at 2.5, haven't upgraded ballooning prior to laser.
Yes. I'm not sure I understand the question. Why did we not use a 3.0 up front, you mean?
Yeah, right from the beginning. After 2.5, this lesion wasn't opening. Why haven't you upgraded to 2.75 and 3.0 and then switched to laser rather than switching laser after 2.5?
So after the first procedure, actually, they had already used a 3.0 non-compliant balloon. So we know that actually what's happened here in that 3-year interval period of time is that the patient has developed some calcification, which has caused some restriction. But that would have been a good strategy as well. That's certainly something that could have been done. But I don't think the vessel would have opened with a 3.0 NC at that stage because it's encased in calcium essentially.
Since Dr. Noori is sitting right me, he also used to say that using multiple wires along with balloon is a poor man rota. That can also be done in such situations.
Yes, yeah. So this is sort of where we're up to at the moment. So we've ballooned up and down this vessel with a 3.0 20 balloon. And I'm interested to hear what people think. Should we just go ahead and treat this with drug-eluting balloon therapy now? Should we think about restenting this? I think certainly the proximal segment of the LED will need to be stented because that is a disease segment. That certainly will need to be stented, and we'll probably think about a 3.5 stent within that. But what should we do about this extensive in-stent restenosis within these 2 drug-eluting stents?
So can you, Sohail, please sum up how would you conclude this case? How would you complete this case?
उसको बताएं ना सिर्फ इसी में वो माइनस करके
Sohail, can you hear me?
Yes, I can hear you.
We just want to know what are the steps because we have 3 minutes to finish, and if you kindly just wrap up, how would you complete?
Yeah, so what we're going to do is that we're going to just balloon further, probably with a 3.5 balloon in that proximal LED segment. And I'm tempted to re-stent this. And there's some data to show that if you use a different drug-eluting stent to one that's been used previously, you have a lower risk of in-stent restenosis. Of course, there's no randomized controlled trial, but there's some prospective data to show that if you use a different drug, that you might reduce the risk of in-stent restenosis. We know that drug-eluting balloon therapy can also be used in this situation as well. So we're going to sort of discuss that with the team here and make a decision about whether we go with a drug-eluting balloon treatment for this segment and then re-stent the proximal, or whether we stent the whole segment with a new drug-eluting stent, a different to the one that we used
So,
previously.
what are the guidelines you see? At what stage you would use to doing any imaging in this case at the end?
Yeah, I mean, ideally, I would have liked to have shown you some imaging, but unfortunately, I don't have the IVUS available to me today.
No problem. Anyway,
Yeah.
thank you so much for nice demonstration for this laser case. We are going to the other lab now. Thank you so much.
Right.
So we switch on to.
Afsar Raza,
Yes.
in earlier days of the laser application, which was withdrawn initially, as you know, it is reintroduced, there used to be a term called lasing and glazing. After lasing, they used to have a bigger balloon than the diameter and open it at a nominal pressure only. And it's a prolonged dilatation at that area. That used to be what they would call glazing.
I'm not sure, but that was a different angle laser. But now I think they have changed the laser technology.
I know.
Yeah.
I'm just saying that laser and then upsize the balloon at a nominal pressure.
Exactly.
For a prolonged period.
That is true. Thank you. So we now go to the second lab, and
We are live?
Dr. Siddiqui, can you listen to?
Okay.
Can you hear me, please?
5 पे जाओ जी 5 quarter 5 value
Hello, Dr. Siddiqui. This is Dr. Raza. Can you hear me?
और मैगजीन आप वो पीछे कर लें
Dr. Amber, would you like to take over? Or?
जी जी मैच पे जाओ जी एप्लीकेशन हो रही है मैच पे जाओ जी
Hello?
Hello, Dr. Siddiqui, how are you? Good morning.
Can you hear me?
Yes, we can hear now.
ये दे देगा 20 दे देगा
Sorry, we're just adjusting the volume. We can't hear you, Dr. Siddiqui. Can you hear us?
26
इसका ध्यान से आगे हो जाए मैं
So, in the meantime, we can discuss Samur, how would you treat this patient? If you don't have the laser, what will you do in this case? If you don't have the laser, how would you treat that instant restenosis?
As pointed out by Colonel Nader, I think it is important to know what is the mechanism of instant restenosis, whether it was lack of proper expansion of the stent to begin with, or it is neoatherosclerosis within the stent. And normally what we do is that we predilate these lesions and we upgrade the balloon size and we take it to the optimal size, that is 1:1 with the vessel size. And sometimes we just dab it, or maybe sometimes we put in another stent.
And if there is neoatherosclerosis, what will be the approach? If you have neoatherosclerosis?
Sir.
Sir,
I mean, we prepare it with the balloon and or other options like brachytherapy is not available
Let's
with
say
us.
simple two options like you see doing the drug-eluting balloon or another stent. Which will be the preference? Any expert? Any? Nadir, what do you think?
Sir, if it's very important to prepare the bed in patients with instant restenosis. And although we don't have cutting balloons here, but it would be a very good idea to use a cutting balloon to prepare the bed properly and then do your drug-eluting balloon or a drug-eluting stent. And if it is neoatherosclerosis, then I would be more inclined to use another stent with a different drug. But in case of stent under expansion or malapposition, I would be more inclined to dilate it properly and use a drug-eluting balloon.
Anyone from audience comments? You see drug-eluting balloon versus another stent within stent?
apart from the NC balloons, I mean, the OPNC, the high pressure balloons, they are very helpful. You can increase the pressure 30 or even 35 atmosphere and keep a long pressure like 5-6 minutes inflations, then deflate for perfusing the coronaries and then come back and do it again. Many a times on second or third inflations that you can crack the lions that way. And I agree with Nasir that it's such an aggressive disease that after having done this, I think the DAB, I would have preferred a DAB rather than, going for the other modality, because the laser itself, it can cause post-laser inflammatory processes which can become even more aggressive in the times to come.
So, Dr. Tahir, do you think that we have enough data on DEB with in-stent restenosis and with drug-eluting in-stent restenosis, not bare metal, is what I'm talking about? Because with bare metal, you had actually never introduced a drug. But here you've already introduced a drug and you've got ISR. So the mechanism is extremely important of why you have ISR, as Nadir and Nasir Saab said. But with diffuse ISR, perhaps it might be better to put in another stent. Although your chances of having stent thrombosis with too much metal on board will be quite high.
I think unfortunately he's in for a
penny in for a pound.
Few
I
more
agree.
procedures.
Yes.
At this stage, I would keep it simple. Give him a good diameter and dab it with a new drug, whatever.
And take your chances.
Yeah. Average.
I think
Keep second stent to another option.
Yeah, can come back 6 months later.
Whatever.
I think it depends on different patients. Every patient, you see, behave differently. You see, some people, they have more tendency to develop restenosis even after a second stent or second treatment. So it all depends, because the exact etiology is not known, whether it is you see some kind of reaction to foreign body, or it is polymer-free stent was another, you see, controversy. Initially, we thought that the polymer-free probably is a better option, but there is still a controversy. They say that polymers can actually reduce instant restenosis. So there is a little controversy going on. Yes, there is a question from...
No, this is a question and comment as well. Although we don't have the intravascular lithotripsy, it also work very well in ISR cases. So it can be one modality.
Sir, continuing on Dr. Amber Malik's point that we don't have randomized trials in such patients because drug-eluting stent ISR is very, very low. And that is probably the reason that these drug-eluting balloons are not still FDA approved. They are only used in the European countries. But another thing is that initially only paclitaxel coated balloons were available, and now we have sirolimus coated balloons as well, which can be used.
And paclitaxel is a weak drug, right? So we're using Limus family, and then we're going to use that paclitaxel on our patients. I mean, our experience is anecdotal, right? It's not real trials, but we do both. We do DBs, and then 6 months later maybe come back and put a stent. Sometimes we put a stent and come back and do a DB later.
Yeah. And another thing, Amber, usually instant restenosis after DES is a focal. It's not diffuse, which is the feature of a non-drug coated.
Yes, but we have found diffuse as well.
Yes, but
just
then the reason is different.
Yeah,
the
reasons are different. So I think reason is really important. Yeah. We should focus on imaging.
Assalamualaikum. Can you hear us in the auditorium?
Sorry for interruption. We now have the second case ready from the AFIC. Dr. Siddiqui, can you hear? Good morning.
We're in Lab B of AFIC, and we're going to do a live TAVI case. We'd like to welcome you all. We have with us our TAVI team, and there's Professor Siddiqui and Dr. Professor Tahir Saghir from NICVD. We've been doing cases with him for quite some time now. I have Pen Ali with me. We have some wonderful team with us, our technicians, Abbas Saab, and our wonderful nursing staff. We have a live TAVI case. Siddiqui Saab will tell you more about the case, and then we get on with the procedure. We have got the lines in. We have got a little change of plan of the axis because of tortuosity. We will talk about the procedure. First, let us introduce you to our case. Siddiq sir, please tell us about the case.
Right, so the patient for TAVI today is... right. So,
Sorry, can we...
the patient
yes, go
today
ahead.
for TAVI is a 69-year-old gentleman with severe symptomatic aortic stenosis. He is non-diabetic and hypertensive and had previous prostatic surgery. His current medications are aspirin, atorvastatin, glimepiride, valsartan, and metformin. On echo, he has severe calcific aortic stenosis with functional bicuspid valve with fused right and left coronary cusp with a peak gradient of 125 millimeters of mercury and mean gradient of 73 millimeters of mercury with aortic valve area of around 0.8 centimeters square. His coronaries are normal. And by parameters of STS scoring and a Euro 2 score, he falls into a low risk category, but since now we have evidence that we can go ahead with the procedure even in low risk patients, so that's why we considered him for this procedure. We are now just started almost half the way down into the procedure.
Sorry, what is
and then myself and Dr. Tahir Sagir will take you along further.
What is the age of the patient, sorry? How old is this?
69.
Thank you. And what is against surgery in this patient, open heart?
Sorry, can you repeat?
Was there any contraindication to open heart valve replacement in this patient?
Well, as such, there was no contraindication, but the reason for not going for surgery was unwillingness to go with the surgical procedure.
Okay, that's fine. And have we already had the coronary angiogram? His normal coronary arteries?
Yeah, he has normal coronary arteries.
Good.
Sir, which wire
on
they
ECG
used
he has
to
a
cross
baseline
the
left
aortic
bundle
valve?
branch block.
Right, okay.
Sir, which wire they used to cross the aortic valve? Was it a straight wire or a Terumo wire? The catheter looks like an AL1.
Yes, crossed with the Terumo wire and AL1.
Okay, thank you.
So finished with the introduction.
Sohail, if you are hearing, can you tell us what are the different wires options we have to cross the valve if you have any difficulty? What are the options we have?
Yeah, we can, in this patient we have used AL1 to cross the LV, but we can change different catheters like right coronary artery catheter, and there are all different maneuvers.
Sir, do you use the Terumo wire routinely, or you use the straight 035 initially, and if you don't cross, use the Terumo?
Nadir, what assessments we normally do here, pre-assessment for TAVI, you see, imaging-wise?
Sir, imaging-wise, we have to do, most of the assessment is done on CT, and we would like the amount of calcification. And secondly, we would like to know whether the valve is bicuspid or tricuspid, because bicuspid valves behave differently as compared to the tricuspid valves. And some people even say that a bicuspid valve is an indication for surgery. Then we need to know the diameter and the circumference at the various levels of the aortic valve. We need to know the depth of the sinuses, and we need to know the coronary height from the from the valve cusps, so that there is, from that we know that if there is a risk of coronary occlusion during the procedure, and if the coronary height is less and the sinus depth is less, so we need to protect the coronary arteries with wires and stents in it, so that if in case there is some occlusion of the coronaries, we can bail out with stenting.
True. I think these are important points, that we have the pre-hand available coronary angiogram, number one. Secondly, I think CT, we can do CT of both the aortic CT aortogram and the CT femoral iliac system. So we need the tortuosity, because many patients are old, elderly, you see, more than 75, 80 years old. Otherwise, open heart surgery is also a good option. So these are the, I think, assessments we need to know about more anatomy of the aortic arch, aortic and the iliofemoral system. Right, so Siddiqui, where are you and what are the next steps you want to?
Assalamu alaikum, I am Dr. Tahir Saghir, Brigadier Officer. I think Brigadier Officer and Professor Nadeem Rizvi Sahab moderating the session there in the hall. We now have crossed the valve, and then we have placed the confida wire in the apex. As this is a bicuspid valve, we are pre-dilating with a 24 balloon. Its minimum diameter is 24.6 annulus, so we are pre-dilating with a 24 balloon. And after pre-dilation, then we will implant a 34 evolutar.
So we were just discussing the pre-assessment. So can you please summarize in your center what is the pre-assessment important before we undertake the patient for TAVI?
Basically, it's Siddiqui Saab has brief about the whole history. This patient is planned for TAVI.
No, the assessment, sorry.
And
imaging and assessment.
He has got on echo. He had a severe calcified aortic valve with the peak and mean gradient of 125 and 73. He has a baseline LBB. On CT imaging, he had a calcified left system with calcium in the ostium of the LAD, and then they did a coronary angiogram. The coronaries are normal.
Thank you.
On CT angio,
Sir,
the patient is having a perimetry of around 87, so at the annulus. So we are planning for a 34 evolutar.
Sir, you were watching the valve under fluoro just before putting it in. So what is the reason for that?
Basically, we have to align the cusps and see the calcification and extension in the cusp or in the LV outflow, or in the left cusp or in the right cusp or in the non-coronary cusp. So we have to take care of all these things. So we have to see it in the high magnification fluoro for the extent of the calcium.
Sir, my question was that after mounting the valve, you were checking it under fluoro. So what are you checking under fluoro after mounting the valve?
After mounting the valve, we check actually the valve, which is well prepared, the knobs that are hooking the valve that are aligned, and both sides of the valve are in parallel position, so that the valve is well prepared.
And so there is one more question. You are going from the left femoral artery. Any particular reason for doing that?
Yeah. Basically, after the procedure, we will run the fluoro. On the right side, the common iliac was very tortuous, number one, and then the bifurcation is very high. Bifurcation is very high, and the inferior epigastric is little bit low. So considering all these things, we switch to left axis where the common iliac is little bit straight. and the bifurcation is little bit low, and then inferior, so the distance is there, so we can easily place our perclose, and then we put the 18 French sheath. As this is a 34, we are planning for 34, so we are be using the inline sheath, but for ballooning, we have to put a 18 French sentinel sheath for pre-dilation, and then afterwards we'll go with the inline sheath for the 34.
Sir, can you please explain what's an inline sheath? Can you
inline
please...
sheath is an inbuilt sheath. When we'll put the device, we'll show you the inline sheath. It's basically built-in sheath with the device, the TAVI device.
Okay.
It's a 18 French system that's outer diameter of 22 millimeter. Now we are just pre-dilating the valve with a 24 balloon. We are taking the minimum diameter of the annulus for the sizing of the balloon.
Sir, do you routinely pre-dilate all your cases, or you only do them in the bicuspid?
No. Basically, in bicuspid we routinely do, but in tricuspid, most of the time we go straight with the valve.
What is the reason of pre-dilating in the bicuspid?
Cases where there is a basically there is a disparity of measurement at the annulus and the intercommissure level. Number one, that has to be taken care of, and then with bicuspid we have to Nadir, just hold on. It's okay, sir. Okay. Basically, in cases where there is a borderline case where we have to decide if we have to take a 23 or a 26 valve, then we also use pre-dilation as a for the measurement of the or assessment for the valve sizing. So we just use the minimum balloon, and on the basis of balloon size, we decide if we go for 23 or 26. During the inflation, we do a rapid pacing and injection. If there is AR, then we upgrade the size, or if there is no AR, then we use the size that is being determined by the size of the balloon. Now we have pre-dilated the aortic valve. Yeah.
So the balloon looked very small as compared to the...
It's a 24 balloon, 24 and 4 centimeter. Sir, just see the, just hold on. ये inline sheet दिखा देगा. एक मिनट, Dr. Nadir, we are just showing you the inline sheet that is being used, that is inbuilt sheet on the device that is being used for the procedure.
Sir, can you please focus on the hands, please?